Hello, and welcome to the Bon Secours Richmond Neuroscience Institute Community Awareness Program. We're very excited to be back here with you today on Comcast for our 6-week series on neuroscience. We hope this year we will bring you lots of information and, more importantly, resources to help you understand our world of neuroscience. Today is World Stroke Day. It's an important day for us to share with you all about stroke and education around the world. We're going to celebrate today, World Stroke Day, and the resources and how far neuroscience has come in the treatment of stroke. I have some special guests that will be with us, and they're going to also share their resources with you. And I'll start introducing them now, and we'll come back and have more introductions and talk a little bit about World Stroke Day. Our first guest is Dr. Ermias Aytenfisu. Dr. Aytenfisu is a vascular neurologist, and he is at Bon Secours St. Mary's Hospital. Welcome, Dr. Aytenfisu.
Welcome. Thank you.
All right. And then our next guest is Mr. David Baldwin. He's the executive director for the Richmond Center for High Blood Pressure, and they are celebrating over 30 years of that service, and we're going to talk about how we are partners and do a lot together. So before they tell you a little bit more about themselves, I want to talk about the importance of World Stroke Day and the importance of why we are all sitting here together to give you some information. It's important for you to know that stroke is the 4th leading cause of death. It also is the leading cause of disability, and that every 40 seconds someone actually has a stroke. And unfortunately, every 4 minutes, somebody dies from a stroke. Now, while that sounds very sad and melancholy, I think our panel today will certainly talk to you about how stroke is preventable, how it's treatable, and certainly how it's preventable. So we're going to start with Dr. Aytenfisu and just talking to us about what is a neurologist and how does a neurologist work in reference to stroke awareness. So he's going to give us a little bit of an intro about himself and how he got into neurology.
My background is neurology, and I specialize in vascular neurology. So vascular neurology is a subspecialty of neurology that deals specifically to vascular disorders that leads to stroke, intracranial bleeding, or spinal cord ischemia or hemorrhage. Neurologists' the role in a stroke is identifying common causes that lead to a stroke and help you prevent those things so that you don't have a recurrence of your stroke in the future. So the main role of a stroke neurologist is finding for the cause that lead to a stroke.
So that's good. And we're going to talk in the show that I always call Dr. Aytenfisu, a neurologist, is like a super sleuth. If you heard him talking about, we're going to find out why. We're going to ask those questions of why you might have those risk factors, and we'll go into that, and how we can help to prevent them. And that's exactly what he does. He specializes that in the vasculature. Now we're going to flip to Dave Baldwin to introduce himself, and I want him to talk about his role and about the center and how we actually work together and the importance of knowing about the center. Because one of the things with that center is that it certainly is one of those risk factors that Dr. Aytenfisu talked about before, of being able to modify or change it so we won't have a stroke.
Pat, thank you. It's great to be here. Like last year, all the efforts that we put into the community and the partnerships that we've shared have been a blessing, both for the patients at the center and those we've not reached yet. They just don't know that they need the assistance. So the Center for High Blood Pressure was born more than 30 years ago under the idea that the risk of hypertension in a young African American population showed statistics that were startling. And so they said, well, why don't we go out, preach the good word, and for those who don't have treatment, we'll treat them. So we specialize in uninsured adults. However, we work with an extended hand into the community. And now, from where we started more than 30 years later, we predominantly treat females.
Wow.
Right?
Wow.
So whether it's because women are better self-advocates, which they are, whether they're more likely to seek health care, they're doing a good job of exceeding men in certain health outcomes. So the center is really designed to keep the patients away from you. So if we're doing our job, they don't have to talk to you yet. So it is all about prevention. The value of the center in the community is in what it prevents, and in particular your strokes, your heart attacks, and kidney failure. So as long as we are teaching and preaching the good word about controlling the things that they can, doing their part to be good self-advocates, then we can hopefully prevent those catastrophic events that you're going to be talking more about.
Okay. Great, David. So I'm glad to hear about women. I mean, one of the things that I wanted to do, I have on my red today, it's World Stroke Day, but I think the one thing that we think about when we see red, hopefully women know about Go Red for Women, a major initiative, and that was one thing the World Stroke Day theme actually is centering this year around women across the world. So I wanted to wear my power red today, and for you to understand that we need to start everyone actually taking care of our heart so we can take better care of our brain. So I want to talk about, while we're talking about it's World Stroke Day, there are important factors. We talked about just a little bit about the Center for Hypertension. But I would like, from a medical perspective, for Dr. Aytenfisu to first talk about a little bit about what is hypertension and our numbers, and talking to that physician, because that's a big piece I think that people don't do. So let's just first talk about what is hypertension.
Hypertension is elevation of arterial blood pressure from the normal range or the standard that's set for your age. It's an age-specific measure, but usually we say systolic blood pressure of 180 to 120 is considered, 90 to 120 is considered a normal range. So when you go above 120 to 140, we call it pre-hypertensive stage. And above that is considered hypertensive, and the lower number is called a diastolic blood pressure, and we expect it to be below 80 a normal healthy individual, but when it goes above 90, that's the standard definition of hypertension, between 80 to 90, we always consider it as pre-hypertensive group. So hypertension that doesn't have a specific symptom, usually you find it with a screening or going to your doctor. If you have a very high blood pressure, sometimes it can give you headaches, feeling dizzy, but that's the extreme case of hypertension. Usually you have to have a regular checkup with your doctor, because a lot of people have undiagnosed hypertension from the hypertensive group. So that's the most important number that you should take from this.
That's good. So let's talk about that. And then, Dave, I'm going to come over to you to talk about that screening, because I know you do a lot there. So how often, Dr. Aytenfisu, should somebody get their blood pressure screened for hypertension? I mean, what's your recommendation? You said age specific. Is there now, and I'm thinking about, I hate to say it, but childhood obesity, or when should you start getting your blood pressure checked?
So there are certain indications that we say if you have body mass index of above 25, we like you to be screened for hypertension at least once a year, or if you have any cardiovascular risk factors like diabetes or hyperlipidemia, all those things, or sedentary lifestyle, those are the risks. But when you get to, when the age advances, your number starts to go up too. So starting at the age of 40 at least, you should have once a year a regular checkup with your primary care doctor. That would be ideal. You can add on what's the recommendation.
Great.
Absolutely. You know, one of the things that we've found in discovering hypertension within the community as we travel around and go to screenings is that people aren't necessarily, especially young people, aren't necessarily paying attention to the adults in the room, their family members. Who else in the family has had diabetes or hypertension? Who's had a stroke? Who's had a heart attack? And until someone says, you need to know this information because it can have an important impact on your health, these young people don't ask. We did a screening years ago at a local school, and these young people were the pictures of health. We screened probably 25 of them, and at least 5 needed to be checked by a professional. Wow. This was a community-based screening, so it wasn't, we didn't have a physician with us. We had a nurse team, but these were young people that never took the time to ask the question about mom and dad's health. So that's one of those big things that people can start thinking about as they start evaluating their own risk of getting something. Just what's the genetic factor?
So callers, we may have callers tonight, and we hope you do call in to ask us questions. The number will be 804-915-5202, and we will take calls between 6:30 and 6:45. So both of you talked about screening. I want to talk about, and I was glad you brought about family history. I want you to talk about, you talked about some risk factors, diabetes, and then having high cholesterol. Those are huge. I'm going to just give you that. Today is World Stroke Day, so now I want you to take it to the next level of stroke. And then, Dave, I want you to talk about diabetes and the other things you do at the center. So what is a stroke? Why do you have it? Why are those things relevant to know, and what causes a stroke?
So stroke can be defined a catastrophic event that lead to obstruction to your blood flow to a part of the brain. We call it ischemic stroke. Usually this happens when a branch of an artery is occluded by a clot or a thrombus that formed in the local area. The second part of a stroke is it's a hemorrhagic stroke, where you have oozing of blood into the brain tissue or into the brain, outside of the brain tissue, secondary to vascular malformations in your arterial wall. So mainly when we talk about stroke, we classify them into two, ischemic and hemorrhagic stroke, and they have a different cause.
Okay. So we said 2 types of stroke. One is ischemic, one is hemorrhagic, and the ischemic one usually has some type of clot, and that's probably due to some plaque formation. And then you have your hemorrhagic stroke, which is like a burst. And so both of them are truly catastrophic, and due to some risk factors that we can certainly modify. Age you cannot, your race you cannot modify that, and definitely your family history. However, there are some diabetes, and then you have your high cholesterol, and certainly hypertension, the sedentary ways, which I know Dave, that's one of his big things about being able to just move and do some things, are some risk factors. So Dave, tell us how the center is helping with that as well.
One of the things that I feel like our practitioners do really well is educate patients on what they can do. We all want to be in control of our health. Sometimes we've given that control over to others, whether it's in the medical community or the lifestyle that our family leads, but those can be detrimental to our overall health. And so education, exactly what we're talking about now, and then the education not only about the disease, but what can I do and what can I do safely, whether it's increasing my activity level, whether it's changing the way I eat. It is an underrated thing that we talk about changing our diet, but some people struggle with specifically how to do it. But Bon Secours also sends registered dietitians to speak with our patients about making those significant changes. When people start changing the way that they eat and increasing their activity, they start taking back control. And in the best case scenarios, you start to reverse the disease process, you know? Unfortunately, when you've got a deep family history and there's genetic components, there's only so much you can do, but it doesn't mean you don't effort the cause. And you don't know how much impact you can have on it until you try. So in addition to that, we manage medications extensively. We do a lot of laboratory analysis. The labs are done for free by LabCorp and Bon Secours, specifically because it's one of the best diagnostic tools our practitioners have. We see them a great deal. There's a lot of case management. There's a lot of removing of barriers. Is it the cost of medication? Is it transportation to an appointment? Is it understanding, you know, I've said it many times, you can have the greatest physician in the world and the greatest medication in the world, but if you can't afford it and you don't understand it, what's the point? So we have to spend enough time necessary to individualize that effort to give them the greatest chance of reducing their risk of stroke dramatically.
Great. And we're going to come back to some of those individually. Again, if you want to call in, the number is 804-915-5202, and we'll take that at 6:30 to 6:45. So it is World Stroke Day. I would be really remiss if I didn't talk about the signs and symptoms of stroke, so that if you do have these risk factors and you do have family history and you are at risk, or if you know someone who are having these signs and symptoms, you want to make sure you act fast. And that is exactly what we want you to do, and that's the acronym we want you to remember. So F usually means, or F does mean, face. We look at your face for symmetry to see if your face is drooling. A means for arms or your limbs. If you raise them and it starts to drift and you can't hold it up, that's a key indication. S also means your speech. That is huge. So if you aren't able to enunciate, pronounce, you can't remember what you were saying, we look at all of that. And then T is so important. We need to know the time of last known well, so that we can treat you. Now I'm going to definitely turn this over to Dr. Aytenfisu so he can talk about that treatment approach for stroke.
So the treatment approach for stroke is two. One is the acute treatment of stroke. So the first thing we have to remember is you have to come immediately to the hospital, especially within the first 3 hours, because that's the we know that there is a treatment if you present acutely within 3 hours. We can give you a blood buster medication that can lyse a clot if you come in within that time window. But if you can't make it within that time window, the current guideline extends that treatment to 4.5 hours. That doesn't mean coming as soon as possible is very important, because every minute the time goes by, your chance of recovery goes down. So we call brain, every time is brain tissue. So we have to stress on that you need to come early. But once you come in, if you're eligible to that treatment, we will provide that to you. After that, the second phase is trying to identify what caused the stroke, and there are categorically for ischemic or like a clot occluding an artery. For that kind of stroke, there are 3 major types of that can cause a stroke. The main ones are if you have a plaque in your large artery. I describe to my patients the blood vessels as a pipe system in your heart. So if you have a rusting in your arteries or a plaque, with time that rust can break off and occlude a small vessel. So if that's the case, especially if it is in the major arteries in the neck, there are treatments, surgeries that we can provide. We call it carotid endarterectomy if you within the first 2 weeks. The second type of stroke is a clot forming from central organ coming from your heart, or it could be from peripheral tissues too. If you have a defect in your heart, the clot can pass through the heart, and those kind of strokes are usually result a large artery stroke. You'll definitely have a major deficit, but finding those usually takes a lot of workup. We have to get echocardiogram, monitoring your heart rhythm so that we can identify if you have irregular heart rate that can predispose you forming a clot, or if you have a defect in your heart. So that's the second major type, which needs a different kind of treatment, where we have to put you on a long-term blood thinners like Coumadin or the new generation anticoagulant. The third kind of stroke, which is very important too, is a small vessel disease, what we call it. This happens in small branching arteries. With time, they get weak because of your prolonged hypertension or microvascular disease from diabetes or hyperlipidemia. For those kind of a stroke, the main treatment is, it applies to all stroke, but for those kind of stroke, the treatment is prevention is very important. Especially hypertension can reduce your risk by 50% for future recurrence of a stroke. Everything adds up to that benefit. If you control your diabetes, it adds up 20%. If you control your hyperlipidemia, it adds up 5-6%. Then that's a cumulative effect. But people tend to emphasize only on antiplatelet agent, but the bigger picture is having like overall picture and treating all the risk factors for that microvascular disease. So it's very important you come in and we try to sort out what kind of stroke that you have, so that we can address the main causes with the type of a stroke.
So as Dr. Aytenfisu said, we have to find out what is the cause behind it. So there are certain kinds, but one thing is we don't want anyone to go back to sleep. Don't go back to bed. I don't feel good. I know my blood pressure is up. Something's just not right. You know, you say, I'll just go sleep it off. That is not what we want you to do. We want you to make sure that you know your body, you're talking to your practitioners, you know your numbers, you're also telling your family history or knowing what is good for you. I do also want to talk to Dave now and talk about the center and where it is. We haven't talked at all about actually where it's located and the hours, because as Dr. Aytenfisu, I was amazed when you said 20%. If you could look at your blood pressure and it goes down, that's huge in cutting down your risk of possibly having a stroke, and then also looking at the other risk factors that we mentioned earlier. But hypertension is such a big thing for kidney disease as well. So I do want Dave to talk about where the center is and the hours of operations, and how is it funded? 30 years is really good. So it is a long time, but it's needed. So tell us a little bit about that.
What we treat is not going anywhere. It's been around a long time, and in some communities it's getting worse, and so we need to be more aggressive. The center, we have been the Richmond Area High Blood Pressure Center for the 30 years, but we do business as the Center for High Blood Pressure, and we are located at 1200 West Carey Street, right on the edge of the VCU campus. You can't miss it if you look for that big red building across from the parking lot that VCU owns. And we're open from 8 to 5, Monday through Thursday, and 8 until noon on Friday. And we're always looking for partners. We're always looking for more volunteers. We're always looking for additional practitioners who are willing to see the patients who might need some an additional skill set. We have wonderful nephrologist. Dr. Daniel Carl is our volunteer medical director. We have a lot of wonderful clinical pharmacists who work with us, and countless others. I wish I had time to name everyone. But the center is really designed as that preventative tool. We want people to stop looking at hypertension as the silent killer, it doesn't bother me, because of what it leads to and why there's so much business in neuroscience. People need to be aggressive about treating it. And you shared the good news. All these things that you can do, whether it's through medication therapies, whether it's through additional exercise or changing your diet, it's that cumulative effect of reducing the risk of having a catastrophic event. People forget that it's the leading cause of disability. I don't know how many times you can say it. So if you survive your stroke 77% of the time, you're left with a long or short-term disability. Who's affected by that? What's the community cost? We are funded out of the grace of the community. We have wonderful partnerships with VCU, with Bon Secours, with local foundations. The Jenkins Foundation has been funding us for many years to make sure that we have a nursing infrastructure in place. And then individual donors who are passionate about the cause that we're fighting for. One of the wonderful programs we have is a medication access program. We partner with the Virginia Healthcare Foundation to access medications through the pharmaceutical companies that are free. But it takes some paperwork, and it takes some understanding of what the individual medications, medications are available, and then again, what's available in the community as inexpensively as possible. Again, if you can't access the therapy, what's the point of the diagnosis? Spend a lot of time doing that. So I'm hoping the center is going to be around a long time and continue to grow and preach the good word.
And I'm glad to hear about the center. It's been around a long time, and it should. I mean, the whole point of the center also is putting us out of a job, but we can transition and come and help in the center and absolutely help again in that preventable stage, and wanting to be able to do that with the partnership. It's about 6:30, so if anybody wants to call in, the number is 804-915-5202, and we will certainly take calls at this time. While we're waiting for calls, I do also want to talk about Dr. Aytenfisu. We're going to talk about medications, because I think that's important, because we talked about blood thinners. And then I also want to talk about, let's do that now. Let's talk about some of the blood thinners, and let's talk about important questions that somebody should come to you and talk about. And then I also want to talk about kind of the honesty factor when they're coming to talk to the doctor, and that they should tell you everything, including if they're on some holistic medications, because it could make a difference.
Yeah, so There are a lot of medication that we, if I understand your question, you want the antiplatelet therapies.
Mm-hmm.
So there are mainly 3-4 antiplatelet regimens that we can provide. None of them are superior to one another.
Okay.
There is a small difference, but clinically they're not, for me, very significant. But the most important thing is, based on the patient profile, which one is a good one for you.
Okay.
So the first one, the very cheap and generic one, is aspirin, which you can buy it over the counter, and 81 milligram. The smallest one is as effective as 325. None of the trials have shown one is better than the other. But if you have a GI problem or irritation from taking aspirin, like burning pain, dyspepsia, Plavix is a good option, which is a different kind of platelet inhibitor. It's generic. There are cheaper options to Plavix too. Both are my first line choices, but if you have recurrent stroke, sometimes we go to Arganox. Arganox is a combination of aspirin and dipridamole. It has a little bit of advantage compared to Plavix and aspirin. The problem with Arganox is it causes a headache a lot of times, so you have to start with one tablet, try to see it over 1 or 2 weeks. You tolerate the headache, and usually it goes away within the first 2 weeks, and you can go to the recommended or the standard dose, which is 1 tablet twice a day. And especially here, we have a lot of African American population, and there might be some new evidences that there is a genetic resistance to Plavix. So you're having, especially in Asian and African American, we see it around 30% in some small studies. So having the standard screening for that, if you have a resistance, you may need a higher dose. So that's one thing, especially if you have a recurrent stroke on top of that. The second line of treatment is anticoagulant, which we specifically use for cardioembolic strokes. In that, we have 2 different groups. One is the older generation Coumadin, which requires monitoring, and for younger patients it might not be feasible to come to a hospital every 3-4 weeks. For them, the newer generation are as effective as the older generation, so that might be an option. But even for older generations, the new drugs could be an option too.
Good. Hold on. Hello, caller. Thanks for calling in.
Hi, yes, I have a question for everybody.
Okay.
You went over the warning signs of a stroke, the face, the arms, and speech, but are there other things that would mimic a stroke that people should be aware of as well?
Thank you. We'll all address that, Dr. Aytenfisu. We can start with you. Thank you, caller.
Yeah, there are other things that can mimic a stroke, like migraine, headaches, seizures. These are the common ones. Or if you have a brain tumor or multiple sclerosis, can give you one-sided weakness. But the most important thing we want to emphasize is any acute weakness should always be investigated. So even if you have a migraine, we want you to come in as soon as possible. At least we want to see the pattern and know that this is a migraine. So it requires 3-4 visits before we say that you don't need to come to emergency department for this. So I wouldn't encourage you to or avoid a visit to urgently to the emergency department.
And the other one that I think is important is Bell's palsy. You can see that as well. But I think the key thing, even if it is mimicking something, we want to make sure that you come in and get checked out. Do not go to WebMD on the internet or any of that. You need to come and get checked out. So I want to go back to Dave for a minute and talk about the center. We talked about their services a little bit, and now I want to talk about the big question while we have Dr. Aytenfisu here. How does one, can we just walk in? What do you need to get started in the center? How do I get, I'm going to walk down there today and enroll. How does that happen? What happens?
Make a phone call, 359-9375. Ask those questions. It starts with education. So we have people who call just for additional information. They're not sure, or they're calling on behalf of a family member. Make that call so that we can try and guide you through whatever process it is, whether it's enrollment. Currently, we serve the uninsured. They are in less than 200% of the federal poverty guideline and don't have any form of insurance. But we do try and meet people where they are. And what we've discovered through the healthcare exchanges is that some people are being left with gaps, like no medication therapy. Well, how can we serve that? Let us discover that. So give a call first.
Hello, thank you for calling. You have a question?
Hi, yes. I have sort of two questions. The first one is, what advice would you give to a patient who's having difficulty being compliant with their hypertension medication? Second, what other strategies along with medication compliance can a person do to continue to lower their blood pressure and get to goal?
Okay. Thank you,
Great
caller.
question.
So I'm gonna start with you, Dave, because I bet you have some you might have some non-compliance.
Compliance.
You might have some experience with that.
There are a number of strategies that we've employed. One of the things is understanding if there is an education problem. Do they not understand when to take it? Is there some forgetfulness going on? Are there some things that are underlying that need to be discovered that could be causing some of that non-compliance? The other thing about it is the additional education required for some folks to understand how important that medication therapy is essential. They're not going to hear it once and then be perfect with their compliance. They have to continue to hear it, and sometimes they have to hear it from the right person. We have had to negotiate with someone to go to the hospital before because they had signs of a heart attack. It was obvious to everyone in the room, but he didn't want to spend the money. Didn't want to, you know what? This is a bigger issue than that, and you have to be firm about it. And for a loved one, it's important that their message not change. If I care about you, I shouldn't have to be the strongest advocate for you. You need to take control of some of that. Discovering what motivates someone to be healthier or to control their disease process is very important. It does take some self-discovery. It does take some self-reflection. And as family members, sometimes we can guide them through that. If a loved one is trying to help with compliance, again, I would encourage a call to some of our health educators who deal with this on a daily basis. Give us an opportunity. You don't have to become a patient to understand more about compliance and what strategies are available. So beyond just those strategies, managing our dietary intake, diabetes is a great example of that. You want to control your blood sugar? Well, you better manage what you're eating. And we can't go into depth about that, but the body was made to move. Physical activity has a wonderful way of righting the ship and making sure your body is working and functioning as it should. And it will also affect how your body deals with the medications that you're being given. These are all things that need to be shared with the practitioner so that they can manage your therapies as effectively as possible. So when you're thinking about, you might be taking something that you don't want to tell the doctor about, right? You're doing yourself the worst disservice by not being open and honest about that. And so these are things that once a patient understands that you're not trying to get anything from them, you're just trying to help, compliance does tend to go up.
And I think I love being a neuroscience nurse. I think, I'm a part of American Association of Neuroscience Nurses, and that's what they teach us all the time, that you have to educate folks and get it to them. Otherwise, they're not going to be accountable or understand that it was very important to say what they needed. And American Heart always has a check, change, control, and you used all three of those words in what you were just saying. But I think, again, it's important, the strategies, and I love your line. I just thought you were going to say with this about exercise. What do you say about exercise, Dave? What is the best form of exercise?
The one you'll do.
The one that you will do. I love him saying that, because there's no need of you setting up, I'm going to run 10 miles today and do this, and you know you're not going to do it. So the one that you're going to do, stick with it. So David talked about compliance. You started talking about medications, and I wanted you to talk about that with strategies. Have you had conversations with patients and saying, I'm just not compliant, and how you've turned that around? Or do you talk to them about being compliant and saying you really need to stay on this, or call me? Or how does that discussion go?
Yeah, usually patients are compliant with antiplatelet agents. When it comes to high blood pressure medication or cholesterol medication, you find them being a little bit negligent, or because it's hard to imagine the effect that comes after 20 years, which doesn't have a symptom right now or a consequence. So sometimes motivating yourself for something that comes as a cumulative effect of time is hard. So you have to really show them. I usually use a picture from the ultrasound of their arteries or the brain pictures to show them the silent effects of hypertension. Usually you see a small vessel disease, or if you have EKG you can show, or echo, you can show them the hypertrophic changes in the heart. When people see, have a visual image what it can do, usually it
Totally,
yeah, that's a good perspective. I had never actually thought about that, and something, I'm not hurting, I can't see anything wrong with me, so I don't need to take this, and so I'm not going to take it. I had never thought about that.
Yeah.
We're coming up on some serious times with the holidays coming around. And so, Dave, I know there are a couple of things if you want to address the holidays in reference to our dietary needs. It's getting cold. We talked about exercise, some other options. And then also during the holidays, sometimes depression can set in. And I want to talk about that, and I want to talk about stress. But Dave, if you can start with some of your pearls or what you've seen or how you think the center has helped people through, that'd be great.
One of the important things is that high touch. And so when our practitioners start to identify some of those situations, especially depressive episodes and things, we will see them more often through the holidays at times. But people may not understand, if you've never been to regular exercises, you don't quite understand the physiological change, the endorphin flow and things like that happen that can help you balance some of those depressive episodes. Controlling our processed food intake during the holidays, sodium intake, alcohol consumption, keeping it moderate. These are all things that will have, if you don't do them, will have a negative impact. And if you don't fully understand what the risks are, it's easy to overindulge and fall into depressive periods. And so the things that we encourage all the time are even more important during the holidays. People have to consider the value of these things. And a lot of people may not be getting the information we assume that they are, so never hurts to repeat yourself again. Maybe this time they'll hear the message. And rely on those people around you. Now, some people may not want to rely on their family members, depends on how the family relationships are, but most studies show that human contact is very valuable in helping people control some of these conditions and keep them balanced in their stress life, their work life, things like that.
So I did just read an article, and they talked about I'm going to give you two things. So they talked about actually having exercise being written by physicians as a prescription. So I want to know what you feel about that. Having and again, that's that visual, tangible. I have to do exercise 30 minutes. It was prescribed by my doctor. What's your feeling on that and helping out with, again, having those risk factors go down? And then talk about a little bit about stress and sleep imbalance and how that is important.
Yeah, I think I agree for some individuals having a prescription for exercise might be a good way to go. It may encourage them or they feel it's medically indicated, which is true. I mean, you need to exercise to lower your risk of a stroke. And it works in several ways. It reduces your blood pressure, reduces your insulin resistance. All that contributes to modifying your risk factor for stroke. So that might be a good strategy, which I never heard before. I might use it in the future.
I'll share that article with you.
And the second part is stress and sleep disorders are very important and as a stroke risk factor, especially sleep apnea. There have been a lot of works within the last 10 years, and it's shown to increase your risk of a stroke or coronary artery disease. Mm-hmm. And it does that by several factors, which could be a little bit I don't want to go too much in detail on it, but sleep apnea, the prevalence is high in the population, especially with the population getting the obesity is becoming prevalent in the population, and that increases the prevalence of sleep apnea. And for individuals that have no experience what a sleep apnea means, maybe your partner could be snoring at night time.
That's the biggest thing. That's the biggest indication.
Yeah, and so those snoring is usually caused by resistance to airflow to your lungs, and people have this recurrent periods of breath pausing phases that lasts more than 10 seconds, and they can occur from 5 to 60 times to the extreme, and we grade your sleep apnea based on how many episodes in an hour that you have. And it's easily treatable condition, but you have to be the compliance is an issue with the sleep apnea too, because the treatment is a positive airway pressure, and some people don't find it comfortable because of their face mask is not comfortable to sleep with. But usually if you try it for a few weeks or months, that discomfort goes away. But if you're not eligible to that, there are oral appliances. Surgery could be another option, as long as you don't have a very severe obstructive sleep apnea. And if you're in that range, and if you don't want to use the next strategy that you can use is reduce your weight. That can put you into milder obstructive sleep apnea, then you can be eligible for surgery. Those are the things. And the stress is also very important risk factor, because it raises your blood pressure. It can predispose you to sympathetic overflow, which can induce arrhythmias in the heart. It can predispose you to coronary artery disease, which as a secondary cause, it can lead you to have another stroke from your coil because of your weakness in the heart. So they're very intertwined processes. Yeah.
So you talked about a lot. I mean, I do think that, again, all of that came under assessment and really knowing your body. So partners, if you're hearing somebody snoring, if they're overweight, we talked about BMI, which, if you really think about your shape, If you have that middle portion that has a lot more love handles on there that you know should be there, those are the kinds of things. Knowing your family history, hypertension is huge. We have Dave here as well. But at the center, they have they help you with all of the risk factors and trying to prevent you from that stroke day, stroke event, as we're talking about World Stroke Day. But I think you have some other things that I don't know if you can share about the diabetes and the research, because you do that's huge for us as well. And callers, you should be, if you don't know this, going to your doctors, and hopefully now we don't have any doctors that aren't doing that A1C test, particularly if you have family history. But they're doing some neat things at the center. If you can talk about that. We have about 3 more minutes, Dave, but I would love for you to just share that.
Sure. We try and be as progressive as possible and discover what strategies may be available to us that perhaps we're not using or have been successful elsewhere that we can easily implement. One of those things is ambulatory blood pressure monitoring. We've been doing a study for a number of years now, sending people home with the ambulatory monitors and evaluating their ambulatory results with their clinical results and trying to put a better therapy together. Can we reduce medication? Do we need to add medication? What are your stress points? There's a lot of information with intelligent providers. They can discern from that to help that patient reduce their risk of stroke. Another program we're going to be involved in is a diabetes prevention model. It is a CDC program. We're one of 7 locations that we're going to be working with our patients through a very specific curriculum, the ones who are not diabetic, trying to keep them from getting there. Because once you're hypertensive, you see this increased risk of diabetes. And if you're diabetic, oftentimes hypertension will be right around the corner. It seems like fewer people have just one thing going on nowadays. There are a lot of complications. And we know that treating each one of those can help reduce the total risk of having a stroke. So between those and the intensive medication therapy program with our clinical pharmacy efforts, I feel like we've had success that well exceeds national averages as far as control rates among our population. So the center is trying to be as progressive and meet as many demands. And one of the things that I wanted to make one more point is, these conditions are bigoted. If you're over 65, your risk of stroke jumps dramatically. If you're African American, jumps dramatically. And not just that, but the risk of not the stroke that disables, but the end stroke. And so if you are in those categories, if you're carrying a significant amount of additional weight, if you're over age 55, if you have one of those conditions, your risks of having a stroke jump exponentially. So ask more questions. Take control.
So you can get information. I want Dave, give your website while you're here. What's your website?
It's simple. It's our old acronym. So it's rahbpc.org, and you can find out who the players are on our team and different information we try and keep published for folks. And of course, just our phone number, 359-937-5. Feel free to call in, ask any questions. We'll guide you to the right resources.
And for us at Bon Secours, you can reach both of us at neuro.richmond.bonsecours.com. And you can write us. If you go to that website, you'll see it say contact us. I'm sure if you just Google Bon Secours and put in neuro, you'll be able to get to our website. You can contact us. You can write both of us, and we'll answer your questions back or give you whatever advice or send you the resources that we feel like would certainly help you to break this tradition or understand that stroke is preventable and certainly treatable and definitely beatable. So one other thing that I want to talk about, I think we have a few more minutes, is TIAs. Can you give us a quick thing about TIAs and what that is and how will I know? And so if I get better, should I just not say anything to anybody, or what does that mean?
TIA means it's a transient ischemic attack. So by all the definition, you have stroke symptoms. It could be facial weakness, as we discussed first, arm weakness or leg weakness that resolves within the first 24 hours. But the most important thing after TIA is the risk of stroke recurrence within the first 72 hours goes up to 15%. Within the first 3 months. The first few days, the risk is 10%, but if you see the whole cumulative risk within the first 3 months, is you have a risk of a stroke up to 15% within the first 3 months. So we want you to come in, have a quick workup, and especially if you have large plaque in major arteries that needs surgery, or if you have irregular rhythm that needs anticoagulation, modifying your risk really cuts down the risk of recurrence by like more than 50%. So it's important to come in as soon as possible within the first week and have a complete workup, so that we can pinpoint where is this, what's leading to your transient neurologic deficits. In a long term, I mean, the risk of a stroke is the same, whether you had a TIA or a stroke. It's the same, so you have to remember those silent warning signs shouldn't be ignored, that you have to see your primary care doctor or a stroke neurologist.
All right, we got about 3 minutes, so I'm going to give you about 30 seconds, Dave, to say anything you want to the audience about tonight and World Stroke Day. And while you're thinking about getting that, I just want to say one thing: know your numbers. You heard Dr. Aytenfisu. The top number should be under 120. That's called systolic. Don't be afraid to ask. And the bottom number should be 80 or below. So I'm going to give you 30 seconds. And the other number that you need to know is your cholesterol level. And I'll just talk about LDL. You want that low. You want it under 100. We call LDL the lethal one, and so you want it low. You want your HDL healthy or high, and so greater than 40. So Dave, if you can give us any of your pearls of wisdom.
One of the things that we know is that, to your point, 80% could be the high number as far as strokes being preventable. If that's the case, there's a lot of work the individual needs to do and a lot of work the practitioner can do to make sure that event doesn't happen. A TIA or what people call a mini stroke, as I understand last year, it's all a stroke. Don't ignore it. Get checked out. To our caller's question earlier, it's so vital that you make sure that you don't ignore those signs and symptoms. I've as an exercise scientist, I've had to use defibrillators in a locker room because someone ignored some signs. And he had them days before. So get that check. Make sure that you're doing the things you can to help yourself safely. And usually that's when you have to work in coordination with your physician. Is exercise at certain levels safe right now? Is it safe to eat certain things or in certain ways or have certain travel plans? Your practitioner can help you do that. And one of the wonderful things that I think our education team does is define everything for you. It's one thing to say you need to be more active. It's another thing to show you how. That's key, and that's what they're able to do.
Good. So you have 30 seconds, Dr. Aytenfisu, so I can wrap it up. Do you have anything else you want to say to the...
I don't have any.
Okay. All right. So remember, today is World Stroke Day. Unfortunately, every 40 seconds, someone has a stroke, and we're trying to prevent that. Hopefully tonight we showed you the resources that you could have to not have a stroke and not be scared of talking to your healthcare practitioners so that they can help you down the path. We also hope you heard a lot about the center, the Richmond Center for High Blood Pressure. For those of you living in Richmond, you should feel really proud to have that resource here to be able to help you on that healthy way. At Bon Secours, we're very excited about this series. We look forward to you having a very good neuro week. Next week, we will be having a special presentation on epilepsy and the importance of knowing about seizures. So we look forward to you tuning in from 6 to 7. We will also have this series on our website at a later date, just in case you need to hear those extra examples. Thank you so much for tuning in.